Hello and welcome, Jess Morley, and who is now currently at Yale University. We're very honored and delighted that she can join us today. Jessica is a health data academic, a postdoctoral research associate at Yale Digital Ethics Center. Prior to this, she was policy lead at the Bennett Institute for Applied Data Science, University of Oxford. She's researched and published extensively on the ethics, regulation, and optimal use of AI and of health data and software in healthcare. So, Jessica, I'll leave it to you now.
Thank you. Thank you so much for having me. So I will share my screen and we'll get going.
Great.
Here we go. Right. So today I'm going to talk to you a little bit about how do we actually get AI right in the healthcare system, and in particularly, how do we get it right in the NHS from the perspective of protecting the NHS's core values, those core values being that the NHS is for everyone, that the patient is at the centre of all care, and that we provide excellent care to everyone free at the point of need, based on need rather than the ability to pay. All of which will become clear that can be disrupted and or enhanced by the use of AI. And we want to achieve the latter and not the former. So we'll talk a little bit about how we do that. So first, let's set a little bit of context. So everybody will know the NHS is sort of beloved in the UK. It is one of the institutions of which we as a population are most proud, quite rightly. But it is also undeniably in trouble. Anybody who has paid attention to anything in the media, but also has tried to access healthcare services, will know that the NHS is struggling to cope. So a little bit of background with regards to the NHS. Everybody knows, I've already mentioned that these were the sort of key aims: meet the needs of everyone, be free at the point of need, based on clinical need, not the ability to pay, and then these core values that everybody counts: compassion, respect, dignity, and improving lives, and a commitment to quality care. But this is the level of crisis that we are now in. So this waiting list tracker is from a little while ago. I think it is now even higher than that. But in general, we have over 7 million people waiting for access to NHS services, in particular NHS operations. This is the highest that it has almost ever been. That figure in red, the 910 million, that was the deficit prior to COVID. It is now much likely to be much significantly higher, given the level of stress and strain that COVID placed on the healthcare service. And all these factors are compounding things that you will have heard multiple times before, I'm sure, rehearsed: aging population, increasing costs of care, reducing resources. Then COVID came in and dramatically made things worse. So there is a solution that exists in terms of policy rhetoric that relies very heavily on this idea that we can use data to achieve what is called the triple aim. So this idea of simultaneously improving population health, the experience of care, whilst reducing per capita cost. I believe that this is a bit of a myth, and that in reality you are much more likely to get a wonky triangle rather than a triangle that looks exactly perfect like that. You can probably reduce per capita cost, but that would have a negative impact on population health or the experience of care, and one way or the other. Regardless of that, this is the sort of narrative that flows through policy rhetoric with regards to the use of data. In particular, it relies very heavily on this idea of P4 medicine. So can we use data and analytics, including AI, to make healthcare more predictive, more preventative, more personalized, and more participatory? The idea being that if we monitor everything about a person's health by using things from wearables, so your Fitbit, all the way through to your electronic health record, through to what you might buy in the supermarket to eat, we can predict how likely it is that you are going to become sick in the future. We can therefore intervene earlier. That will make the cost of care lower, and personalized by making it more effective and targeted specifically to you. So that might be things through like epigenetics. So you see these types of things in rhetoric that appears in statements such as this: our vision is for the UK to have the most advanced and data-enabled clinical research environment in the world, or by 2030, the UK has a learning healthcare system delivering better outcomes for the public enabled by the effective use of AI. Or we will seize opportunities to support the NHS and patients through innovative NHS data partnerships. So how do we do this? Well, This is where we enter clinical decision support software. So clinical decision support software, anybody who's ever been in the GP's office will have seen something like this that you might pop up on your GP screen. For example, if I go to my GP, I will normally see a pop-up that says Jess is a female over the age of 25. It would be good to remind her to come for cervical screening. That's a very basic form of clinical decision support that has been in practice and in use since the 1980s. What we are talking about when we see policy rhetoric like this idea of P4 medicine is much bigger, or what I call algorithmic clinical decision support software. So this is where we are using AI or complex machine learning models behind the scenes to work out all of the factors that might be associated with increased or decreased risk for a particular person, and then really predicting the level of risk that that person might be exposed to. So this is an example. This is not machine learning. This is linear regression, but it would scale up even more. This is a model that we built during COVID to identify who was most at risk of negative outcomes from COVID. That was then deployed across the NHS to help with the shielding list, and then ultimately to help with the identification of the vaccine rollout. That is an example of algorithmic clinical decision support software. The basic idea works on this concept of patients like me. So the model will know every other case that has ever seen of a patient that matches your profile, whether that be your demographic profile, whether it be your genetic profile, whether it be your phenotypic profile, ideally all of those things, and say, in these cases before, the most likely result was X, and the best way to prevent this is Y. The issue is that there is a massive gap between expectation and reality. So this is my favorite slide to illustrate this fact, because these two things happened on the same day. On the same day the NHS published its buyer's guide to AI in healthcare, we had the news story break that 16,000 COVID cases had been lost because the wrong Excel formatting had been used. So we cannot simultaneously say that we are going to solve the NHS's crisis by using AI and algorithmic clinical decision support software when our infrastructure is not fit for purpose. We also know that the NHS has an extremely poor track record in achieving these goals. We have things have happened, for example, with the NHS plan for IT, NP-FIT. We've had their care.data. More recently, we had that with GPDPR, so the general practice planning for response and research. And we've seen issues happen with like the NHS Royal Freeze partnership with Google DeepMind. So the question comes, should we just give up? Well, no, this is where we get into the chat about values. You see, if we go back to the NHS constitution, we see that there are things in there under these commitments to the highest standards of excellence and professionalism, that the NHS is committed to innovation and committed to improving lives. That means that there's an ethical imperative to explore any technologies and innovation that have the potential to save lives. That's also built into human rights logic. If anybody has ever gone and read the UN Convention on Human Rights, there is a line in there that says everybody has the right to benefit from scientific endeavor. This is the same type of thing that is saying everybody has the right to benefit from innovations that may save lives. So we have to, by definition, explore the potential for these technologies. So we end up in a quandary. How can the NHS be enabled to capitalize on the dual advantage of AI? So that is, how can it be enabled to capitalize on the benefits whilst mitigating some of these harms to do with wasted resources and opportunity costs? And that, how do we also do it when we know that the infrastructure is not fit for purpose? So this leads us to this question: what are the information infrastructure requirements for the successful implementation of AI in the NHS? And successful meaning technically feasible, socially acceptable, ethically justifiable, and legally defensible. The issue is this is really, really, really hard to do. It's far more complex than it comes across in policy, or in fact across in many academic documents that talk about, I have built this model, we should deploy it in the NHS immediately because it will deliver X, Y, and Z. This is a model that's produced by Trish Greenhow and colleagues many times. It's called the NAS framework, so the non-adoption, abandonment, scale up and spread of technologies. And essentially what this says is that if a technology is complex in more than one of these areas or these domains, all the way from the conditions through to embedding over time, then it is more likely that the technology is going to fail. So if you look at AI is hyper complex in every single one of these domains. It is not trying to predict just one condition that is well understood and that is well treated and that we know the demographic really well. This is in fact trying to predict everything for everyone. That is a far harder task. From a technological perspective, we don't understand it very well. There are issues with the fact that it's a black box, which basically means that we don't know how to interpret how these models have reached their decision. It's extremely complicated to embed in existing NHS infrastructure, most of which is very laggy. If you've ever tried to use like an EMIS interface, for example, if you are a GP, you will know that these things are not super well designed. There is anything between 4 and 17 different electronic health records used in NHS hospitals. And there's also a wider problem in terms of the social development. So we have issues with public trust. Public trust is at an all-time low with the use of secondary uses of NHS data. And we don't have a particularly good regulatory regime for the use of software as a medical device. And then the last point is that we know very well, or the NHS knows very well, how to deal with static technologies. It knows how to approve a drug, and that drug is never going to change. It's going to stay the same for the rest of time. AI does not. AI changes over time, and we just do not know how to use to do this. But really, the main point of talking to you today, given the focus of this particular symposium, is to talk about how this might actually disrupt things from a value perspective. So if we think about the fact that it's extremely complicated to get it right, there is therefore a need to think about how we get it right, because if we do not design these types of technologies correctly, what you are going to get is a complete disruption of the NHS's value. So hence this thing, be careful what you wish for. Ultimately, the issue is that AI can disrupt these three things. It can disrupt the knowledge about the body, it can disrupt the therapeutic relationship between a clinician and a patient, and ultimately it can disrupt the relationship between the body, culture, and society. And by combining these three things, each of which I will talk through in a little bit in 1 minute, is that you will result in displacing all of those core values. So we will undermine the excellence and empathy of care. We will displace the patient from the center, and we will certainly not see the NHS being available for everyone in the same way that it aims to be now. First of all, knowledge about the body. You are the expert in your body. You know when it feels wrong. You know when you feel well. You know if something is off. An algorithm will only know, or AI will only know what is wrong based on what is recordable, and particularly what is recordable in a quantifiable way. So algorithms are using things, or AI is using things that is recorded in an electronic health record, that is recorded in your Fitbit or the app, the health app in your iPhone. These are actually relatively narrow metrics. They are not based on anything to do with the sort of haptic or kinetic sensations of your body. They are based on what is recordable and what is quantifiable. Do you have a SNOMED code recording for whether or not you have been pregnant before in the past, for example? What is your height? What is your weight? What is your genetic profile? All of these things are extremely important, but they don't take into account things like, how do you feel? What is the best things for you based on your current lifestyle? So for example, maybe treatment X is the most effective, but it's not the best for your lifestyle. AI struggles very hard to deal with that kind of concept. If we were to talk about using AI to model waiting lists, for example, AI will try and optimize the best solution for a waiting list based on who is most likely to get the longest, best outcomes of that surgery, not on who is the most in need of it. And that might mean, for example, that you discount or exclude people who are likely to die, because that is not the way in which an algorithm would optimize. But these types of things about the knowledge about the body, how do I feel, what matters to me, are extremely important. And what we are doing instead is creating a scenario where it is no longer the patient who is the best expert in their body and in what is their health. In fact, it is an AI or an algorithm or a model that is the expert. And when you have this factor in this thing called automation complacency or automation bias, which is essentially the idea that people believe computers are always right, we start assuming that if the algorithm says Y, then that must be yes. The algorithm says this is the problem, therefore that is the problem. Even if the patient says, no, that's not the problem. Actually, I don't have a headache, my stomach hurts. But the algorithm said you have a headache, therefore the algorithm is right. So disrupting knowledge about the body. Then there is this issue of disrupting the therapeutic relationship. The therapeutic relationship, I don't need to tell people in this room, but it's fundamentally based on trust. It is based on this idea that the doctor is acting in the best interests of the patient and that the patient is being treated as an individual, and the doctor is taking into account all of the things to do with that patient and then applying their knowledge to that specific patient. It is a trust-based relationship. That trust is essential to effective and caring care. And we also know that very human values matter extremely importantly in that relationship, things like compassion and empathy. Even if those are things that are not necessarily measurable, or we do not necessarily have a scientific explanation as to why they matter so much in achieving good patient outcomes, we know that they do. AI is acting as a mediating relationship in that basis. So it is suddenly making calculations that neither the doctor nor the patient necessarily know. It is making things and making recommendations based on a model that has been trained by somebody who is not the doctor, who we do not know if it had the patient's best interests at heart. And it is based on knowledge that's not necessarily related to the patient, given what I have just said about knowledge about the body. So already you've got that mediation in the middle, and a doctor might not feel confident in being able to question it. On top of that, the way in which algorithms or AI might present the results of anything that it has done is very unlikely to be genuinely, meaningfully empathetic or compassionate. We can teach models, we can teach chatbots to mimic empathy. That is a very different thing to actually being empathetic. So we might want to think about, when would we deploy AI in what scenarios? It might be absolutely fine for a person like me to use AI to do a quick bit of automatic triaging if I need a prescription refilled. That is probably totally fine. I don't necessarily need to talk to a provider in order to have that conversation. It's probably not going to negatively affect my experience of care, and it's probably not going to negatively affect the long-term relationship that I have with my clinician. If, however, we were talking about things like end-of-life care planning, that is something that we probably do not want to be mediated by an algorithm, because it is something that we know requires an enormous amount of empathy and compassion, and that sort of very, very important trust. And so unless we think about those types of red lines, unless we also think about things like human-computer interaction, so how do we design AI so that doctors feel able to interpret the results, they feel able to question the results, they feel able to tell the patient what this means to them specifically, we will end up with a negatively impacted therapeutic relationship. Patients will have a worse experience of care, and we know that a lesser experience of care actually has an impact on outcomes. And then finally, we have this issue with relationships between body culture and society. People have probably heard the word bias bandied about a lot, either in the context of AI is definitely biased, or sometimes you hear it in the other way, where it says AI is going to be less biased than clinicians. Clinicians have all these inbuilt biases, and an AI is going to be sort of objective, and it won't have any of those biases in there. The reality is that both of those things are true and not true at the same time. So yes, human clinicians are biased. Yes, we can train algorithms to be less biased than a clinician in the way in which a bias presents in a clinician. However, algorithms, AI, is trained on data produced by existing clinicians. So this idea that there is no bias in the model is not true, because it is trained on historical data. We know that historical healthcare data is extremely biased. We do not have good data on people of color. In particular, we do not have good data on women of color. We know that there are enormous amounts of issues to do with outcomes of people for example, women of color in maternity care. We know that it is atrocious. If we train an AI on those types of data, we will get the same results. There is also issues to do with the way in which these algorithms are interpreted. If you are interpreting severity of pain, for example, we know that women's pain is taken less seriously than men's pain. An algorithm will learn to mimic that. And ultimately, all of these things start to do is stigmatize different groups of people. So let's take a hypothetical scenario where, if we go back to that beginning and we're talking about P4 medicine, so predictive, preventative, personalized, participatory, the idea there really is that the onus on taking care of your health and not becoming sick is on the individual patient. So what the logic is saying is, If I have told you that you are at risk of developing type 2 diabetes, for example, and you do nothing to minimize your risk, you then become type 2 diabetic, it is your fault. And therefore, the healthcare system is absolved of its responsibility. Now, what happens if we have an algorithm or AI that is starting to diagnose or predict that people who have pink hair and green eyes are the most likely to achieve or to receive a diagnosis of this particular condition? We also know that these people don't do anything about it. They become stigmatized, and we start to change this relationship between the body, the culture, and society, where we start to see some people as less worthy or less good patients because they are more at risk of developing certain conditions, and yet they are less able to act on that information. The thing that is complicated about that is that acting on information is not necessarily straightforward. There are multiple things that affect whether or not a person can act on information. That might be their social determinants of health. So that might be their lifestyle. It might be their economic circumstances. It might be their familial circumstances. They might be a carer, all of these things. But it's also things like health literacy or digital health literacy. How skilled is that person in interpreting digital information? So we have this issue where we know we have our biased algorithms that are more likely to work well for some people, particularly white men, but less likely to work well for others. We know that they are likely to reflect historical biases, which often indicate that there are things like race-based relationships with risk. We know that if we hypothetically push out this idea that if you don't intervene based on what an algorithm has told you of your risk profile, you are to blame if your healthcare comes wrong. And then we suddenly see this shifting between the relationship, the body, culture, and society. So we really have to think about how do we design infrastructure to make sure we overcome that complexity and that we do not disrupt the core values of the NHS by fundamentally changing what counts about knowledge about the body, the therapeutic relationship, and the relationship between body, culture, and society. So the things that we have to think about then is how information, technology, processes, objectives and values, skills and knowledge, and management systems and structures. So we need to think about the data quality, the data relevancy, and its data representativeness. Do we have data that is representative of the population? Is it of sufficiently high quality for everybody that we need to be able to treat? Do we know that the data actually represents the thing that we think it does? So for example, is it definitely indicating this condition versus that condition? We need to think about interoperability, access, privacy, usability, and in particular, we need to think about validating and verifying the results of algorithms. Have they been tested in one environment and then trained in a different environment? Do we know, for example, that an algorithm developed and trained and tested in a London hospital is going to work just as well in a Manchester hospital? Probably not. Has there been an evaluation process? And we need to really think about how we build these values into the design. So we need to think about value pluralism. This means that we cannot design AI algorithms that are going to be paternalistic and determine say, this is the best way to treat this patient, regardless of what they think is best for them. That is an entirely wrong thing to do. That does not take into account things like spirituality, religious beliefs, cultural sensitivities, and individual preferences. And we also need to think about the skills and knowledge of clinicians. How do we make sure that they understand what is happening in terms of data ethics, in terms of clinical informatics, in terms of how do we build these things into a clinical pathway? This is not the same as replacing blood pressure cuff A with blood pressure cuff B. We are transforming the healthcare system by implementing these types of models. We have to think about how they impact the entire care pathway, because that matters just as much in terms of achieving the value protection that the NHS wants, as does the validating the individual model. The problem is, I'm not going to tell you what these numbers mean. They are fairly irrelevant. The gist is that at the moment, current policy direction means that these foundational requirements are unlikely to be achieved. So we are at the moment in a scenario where there is a very big push and a very big drive to implement AI into the NHS, and yet none of the requirements that would mean that it is safe and that would mean that it, in particular, that it is deployed in a way that protects the NHS's values is likely to be achieved. The reason why this is because of these 4 things. So first of all, there is an extremely deterministic attitude that is very prevalent inside policy at the moment. This is the idea that technology in and of itself will solve problems regardless of how it is designed. This is why we see lots of emphasis from the government at the moment on adoption. So there is a £21 million fund to encourage the NHS to adopt AI. There is not an equivalent £21 million fund to encourage the NHS to evaluate whether or not they are ready to adopt AI. Then there is this issue of the frame problem and epistemic community. So essentially what this means is that the way in which these AI technologies are framed, that P4 medicine thing that I mentioned at the beginning, is misleading. We are trying to give the impression that AI can solve all of the problems all of the time. It probably cannot. It can do a few things very, very well. So it can focus on information needs rather than information wants. It can make sure that at the point of need, when I have a specific question, AI provides me with the specific piece of information that I need, and that will help me achieve the goals that I want to achieve for my patient at that particular moment of need. It probably is not appropriate to be using it to predict all things at all points, at all times. And any kind of rhetoric about AI being able to replace clinicians is complete and utter nonsense. It's not technically capable of doing that, but it also would be extremely damaging from an ethical and value-based perspective. And then there is this thing of epistemic community. So this is really the last thing that I will say on this particular slide, is that we have an overarching influence of the technical community. So at the moment, that much of policy direction is developed and encouraged and facilitated by the technical community. So those are people who are developing AI. These are people who are brilliant at what they do, and it is no fault of their own, but they do not have experience of healthcare and they do not have experience of the NHS. And so what we need is more discussions like the one that we are having today and that you are having in the room. I'm sorry that I can't be there, about how do we make sure that people who are social scientists and clinicians and ethicists are involved in influencing the way in which AI is designed for the healthcare system and the way in which policies are designed to facilitate its implementation, because these things are just as important as designing the models in and of itself. So what is the recipe for success? And this is my final point, that I would encourage everybody in this room to focus on these 4 words: utility, usability, efficacy, and trust. Whenever you see any kind of discussion about AI in regards to the healthcare service, and in particular with regards to the NHS, put your skepticism hat on and say, is it useful? Is it delivering something for the healthcare service that we actually want? And that if I was designing the technology, this is what I would ask for? Or is it something that is being foisted upon me because a technological determinist or a tech enthusiast has decided, hey, the NHS has a lot of data, let me build a cool model and then give them the model? That's not the way around we want things to go. We want the NHS to be saying, I have this specific problem, please can you go and build me a model that will help me solve it? Is it usable? So is it interpretable by the clinician? Is it interpretable by the patient? Is it something that is embeddable within a care pathway that isn't going to disrupt things, that isn't going to make a clinician be completely unable to tell their patient how they have reached that diagnosis or their point of or their particular treatment plan? Have we made sure that it is not something that is going to cause a massive knock-on effect? So for example, if we put in an algorithm to speed up the process of breast cancer screening, have we also thought about how will we treat the increased number of people who are likely to be exposed of risk or told that they are exposed to risk of breast cancer? Is it efficacious? You would think that this is a basic. We have had evidence-based medicine now for basically the entire time that I've been alive. We should think about efficaciousness of algorithms, but what we have at the moment instead is hyperbole, hype, and spin. So what you tend to see is papers published or statements that come out from the government that say, hey, we've got this model and it can predict at an 85% accuracy your risk of developing vascular dementia in 20 years' time. Okay, has that model actually been tested by an independent group? Have we subjected it to some form of clinical trial? Do we know that it is safe? Do we know that it works for every single type of patient? Where are the gaps? Where are the edge cases? What are the safety implications? And importantly, because this is the bit get missed all the time, what is the actual effect on clinical outcomes? That gets missed. There is an assumption that statistical accuracy is the same as clinical efficacy, and clinical efficacy is the same as clinical impact. Those three things are not necessarily true. We want statistically accurate algorithms, yes. We want them to be able to make a clinical decision that is comparatively effective compared to what we are currently using, yes. But ultimately, what we want to be monitoring is the long-term clinical outcomes and the long-term clinical impact. We need to be testing for those three things. If there is no mention of any of that type of thing in the context of the algorithm or model or paper or whatever you're reading or looking at or being presented to at a tech conference, then immediately red flags should start waving in your mind. And then the last one is trust. We have to really realize and emphasize and remember that trust is the foundation of healthcare. We have to trust the healthcare system. We have to trust our individual clinical providers. We have to trust our colleagues within the clinical system. AI can disrupt all of that. It can use data in a way that is unacceptable to the public. It can produce results in a way that is uninterpretable and unexaminable and completely inscrutable, and therefore probably unsuitable for patients. And it can mediate that all-important relationship between the patient and the clinician, because it can feel as though the patient's personal interests are not being taken into account by the doctor. Instead, the doctor is trying to optimize performance by using the algorithm. This is a concept called uniqueness neglect. And it has a devastating impact on patient outcomes and patient trust, and that relationship between the patient and the clinician. So I will end on this message that be skeptically optimistic about the use of AI in healthcare. It can do great things. It can also do terribly bad things. We have to design it to achieve the good things and to be optimistic. And it will only achieve that if we focus on these four concepts of utility, usability, efficacy, and trust. And now I'm going to stop because I'm out of time. Thank you very much.
Oh, thank you very much, Jess. That was fantastic. I mean, so informative. And so I'm going to see if I can get myself back in view. So self-view. I hid myself. Yeah. And so many really important concepts and ideas that, you know, I'm going to re-look at your talk, because there's so much there. And just to tell everyone that a book is coming out hopefully this year, A Companion to Digital Ethics, and there's a chapter that you have written with others on the debate on the ethics of AI in healthcare, a reconstruction critical review, which is a really, really useful and informative paper with looking at all the ethical concerns and also the levels of the personal, the interpersonal, the group, the sector, society. So, and it's so clear and so relevant. And I very much hope that you and others will be able to influence the policymakers and the leadership of the NHS, because this is such important stuff. So thank you very much, Jess.